All right, I'd like to introduce a friend and a colleague of mine, Dr. Dawn Wilson. Dr. Wilson is one of our pediatric endocrinologists all the way from Fort Worth, Texas at Cook Children's Medical Center. Dr. Wilson has devoted the past 20 years of his career to cardiovascular health and risk prevention in children and adolescents. Recognizing that cardiovascular disease is a leading cause of morbidity and mortality in the US and developed countries, Dr. Wilson developed 3 unique cardiovascular health and risk prevention programs as a member of the academic faculty at Texas A&M, University of Arizona, go Cats, and Texas Christian University. Currently, he serves as the endowed chair of the Cardiovascular Health and Risk Prevention Program at Cook Children's in Fort Worth. This program is designed to better understand the causes of premature cardiovascular diseases, including genetic and acquired forms of dyslipidemia, diabetes, and weight-related health risks. As an expert in clinical lipidology, Dr. Wilson has been invited to numerous presentations and written editorial comments for leading peer-reviewed lipid, lipoprotein, and cardiovascular disease-related journals. Dr. Wilson participated as a co-author for the National Lipid Association's recommendations for patient-centered management of dyslipidemia, and recently shared the Lipoprotein A Scientific Committee statement. So everyone, please welcome Dr. Dawn Wilson.
Very kind. Well, it's great to be back amongst so many friends, and brought a couple of colleagues here to answer the hard questions. But I also consider Oklahoma my home. This is kind of my first formulative job up in Tulsa for the first 12 years, and then I was at Arizona, which Jill has some fondness for, and so it looks like I can't hold a job. But so my. It's another interpretation. So my task today is actually to encourage you to think a little bit about, particularly you younger colleagues, lipids as part of our calling in terms of endocrinology. And the reason I got extra interested in this is when I was in Tulsa, we had a great group of people that we worked with, but the young people that we took care of, particularly with diabetes, for the first 20 years, we had NPH and regular, which the kids took sometimes, but what happens about midway through my career, those kids started dying. And I naively thought that they were actually dying because of DKA or those things that we usually see. But the reality is they were dying of cardiovascular disease in the early 30s. So these parents, which were near and dear to my heart, would call you up and say, gee, I just want to let you know that Johnny died. And you think, oh my God, what? Car wreck, whatever. And no, they were having cardiovascular disease. So I realized at that point that what we do on a day-to-day basis is extremely important, but what we need to think a little bit about is the long term. How are we going to get these kids not only to survive and do well with their diabetes, but avoid cardiovascular disease? But that's also true of everybody in this room, by the way, because what Jill said is true, and that is this is the leading cause. So if you look at all cancers, which are horrific by comparison, both men and women, it's multifold increase. And it's, for the most part, a preventable disease. So I don't have any relevant disclosures. I'm going to briefly talk about lipids and lipoprotein metabolism, talk about cholesterol screening, and encourage you to work with your pediatricians in your community to get this done, because unless they identify these asymptomatic kids, you're not going to be able to do much. Mike was asking about lipoprotein A. I'll talk about that briefly, genetic testing, and then emerging drug therapy. So some of you probably have seen this before. I've talked about kind of the basics of cholesterol metabolism in the past. I have the privilege of teaching medical students, as many of you do. And what I love about medical students are their ingenuity. So I showed this slide and I said to them, what do you see here? And one kid shot up his hands and this was his response. Now, I don't know if you know, I thought that was pretty clever, but looks like the blank faces and amongst the medical students, they didn't have a clue. So for those of you who are not art connoisseurs, this was Picasso's rendition when they Franco started the war and started killing people. He responded by this. This is the most iconic anti-war painting that you'll see. So I gave the kid credit. I thought he was pretty clever. So just as a refresher, when you measure cholesterol, you get a standard lipid panel, total cholesterol, triglycerides, HDL, and then the LDL is actually calculated. It's a calculated number. You can measure it directly. It's a separate test, separate cost, but it's actually a calculated number. So the endogenous process is that the liver makes cholesterol, takes cholesterol and triglycerides. It forms a complex with ApoB. ApoB is just a ligand, so it's a protein on the outside surface of that molecule, and it spits out something called VLDL. It's just a density measurement. That VLDL's whole mission in life is to distribute energy vis-a-vis triglycerides to the cells. And if you're not using it in your muscles, guess where it's going to go? It's in your fat cells. So no magic there. It gets stripped down then as you start taking triglycerides out of that to IDL and then LDL. So the origin of LDL cholesterol is actually endogenous production of VLDL. Pretty simple. Okay. There is cholesterol in those molecules, but it's not utilized in any way. So it's just recirculated back to the liver and or excreted in the stool or recirculated back as VLDL. So you could ask the question, well, what the heck is the purpose of LDL cholesterol in the bloodstream? And the answer is probably I consider it exhaust fumes, right? We're distributing energy, but the reality is LDL or cholesterol in general doesn't cross the blood-brain barrier. Number two, every cell makes its own cholesterol for purposes of whatever it's going to do, cell membranes, vitamin D. We've actually looked at some of our kids who have extremely low LDL cholesterol because of genetic issues. So they have an LDL 10. Their steroid metabolism is perfectly normal. So again, I question whether the LDL cholesterol in the bloodstream has any purpose whatsoever other than cause problems. So when you order this, when you order triglycerides, the lab doesn't actually measure triglycerides. What it does is hydrolyzes triglycerides in the sample and measures glycerol. So remember that triglycerides, just 3 fatty acids, whatever length they are, short, medium, long, and they're hooked onto glycerol. And the reason I mention that is there's something called pseudo hypertriglyceridemia. What it means is that you actually have excess glycerol in your bloodstream. So how would you have that? Well, glycerin suppositories, easy answer. Other medications contain glycerol, and there's a glycerol kinase deficiency that we all know about. So you can actually have pseudo hypertriglyceridemia based on just a false measurement. So it just approximates the triglycerides based on glycerol, 1 glycerol molecule per triglyceride. The LDL is a calculated number. We used to use something called the Friedewald equation. You basically take the total cholesterol, you subtract out the so-called good cholesterol in the HDL, and then you divide triglycerides by 5. So it assumes that the cholesterol content in triglycerides is 20%, but the reality is it's somewhat variable. So we now have a new equation that you probably see in your lab reports called the Hopkins method, and that's pretty much what all the labs have gone to. It uses a variable number to divide the triglycerides, just recognizing that the cholesterol content varies by the triglyceride content. And then HDL is actually a measured number. So each of these molecules contain cholesterol. So when you're doing a total cholesterol, it's basically the sum of all those. But really, what you're really interested in is the atherogenic lipoproteins. And for that, you basically just have to look at these ApoB particles. So everything you see with that little yellow protein on it is B for bad, right? So it can actually become atherogenic. The LDL, as I said, is a calculated number, but the reality is unless you measure lipoprotein A, you don't get the full measure of what you're dealing with, because you'll get the cholesterol content, which is, so LP little a or lipoprotein A is basically the cousin of LDL, bad cousin, if you will. It's just the same molecule. It's just got a small little A protein on it that is both atherogenic and prothrombotic. So it's associated with strokes. But unless you measure that, you actually won't know where all the cholesterol is. So it's the sum of those two that's really the cholesterol. The flip side of that is you start treating LDL cholesterol, which is kind of what you measure, they estimate in the lab for you. It may go down to a certain level and stop. It's going to stop because you're not lowering the cholesterol in the LP little a, and you don't know it's actually there. And then we do what we usually do best. We accuse the patient not taking their medication, right? But you can actually measure the ApoB particles. So these little yellow dots, you can actually measure them. It is a separate test, But I'll tell you, it's hands down the best test that you can do in terms of looking at particle number, which is really where the action is. The number of particles is going to be the best indicator of atherogenesis. You can also calculate free of charge a non-HDL. Basically, you just take the total cholesterol, subtract out the good cholesterol. So basically what you're left with is cholesterol content up here, not here. And it's an okay approximation. Oh, sorry, thank you. It's an okay approximation. The problem is it's cholesterol content. It's not particle number. So it's okay to use. It's free of charge. A lot of times the commercial insurances may not pay for the ApoB. At least in our state, Medicaid will. But if you start looking at ApoB, you can't go back. Cholesterol screening. I think most of you know the screening recommendations starting at age 2, if there's an indication like the parents have hyperchloesterolemia, they've had an event in their family, men less than 55, women less than 65, or the child is adopted, you don't know what their history is. Then you go ahead and just test them at age 2 and above. So hopefully pediatricians are taking somewhat of a history and they would go ahead and initiate that. My experience is they almost never do. However, when they get to 10 years of age, irrespective of their family history, irrespective of their health history, then the American Academy of Pediatrics has in the Bright Futures schedule cholesterol testing of all kids. Now, how successful are we getting people to do that? Well, the average probably is about 3 or 4% of practices. Now, in areas like ours, where we really worked hard to get the pediatricians to do it, we're probably up to about 40. But nobody's getting close to 100 except Slovenia. Who would have thought, right? Who even knows where Slovenia is? But Slovenia actually implemented a universal screening program at age entry to school, which is 5 for them. So you have to have your immunizations and you have to show your cholesterol level or else you can't go to school. So they actually got up in the high 90s. Yeah. They're presented at every meeting because of their exemplary program. So the United States jumped on board with universal screening. Now the Europeans are in the process of trying to get European countries to do it, the EU folks. But here's the deal. Is fasting necessary to do a lipid profile? The answer is no. Yeah, in fact, it's a deterrent. So if you think about it, we're interested in cholesterol. We're not interested in triglycerides. This is for FH screening, right? Triglycerides are not in. We'll get into this discussion about atherogenesis of triglycerides, but the reality is we're looking for FH. And so if pediatricians have to tell the kids to fast, it means that pretty much everybody except the first appointment of the day is going to go out with a lab slip that they're not going to do, right? Because the kids have to take off school, mother has to take off work. It's a deterrent. So please, please, please ask your pediatricians, forget what we taught you in medical school. Because as Brian and I gotten a little bit older, we tell them a lot. We really didn't mean that. It was good information at the time. But tell them not to do fasting. But if you have a kid who comes to your clinic, now you're getting these kids who have insulin resistance, type 2 diabetes. They're much more prone to have significant hypertriglyceridemia. Or if you have the kid on a treatment and you want comparability, then I think it's reasonable to have them fast. Now, fasting may mean they only ate half the breakfast or they just stopped at McDonald's on the way in, but whatever that means. So for the vast majority of adults and children, consumptions of an average sized meal will minimally affect your lipid profile, minimally, okay? Only 10% of kids are going to have triglyceride levels over 120, 150. Now, I know you're going to say, well, that ain't true because I say a half the dozen. Well, okay, but you got a biased population, right? I'm talking about a general pediatrician's office. Is there any proof to this? Well, yes. Here's almost 13,000 kids. And if you look at it, I don't know that you can draw a straighter line for any of those numbers, including total cholesterol, LDL cholesterol, HDL cholesterol, and there's a little bit of a bump for triglycerides. It's about 23%. So it means if your triglycerides are 100 and they didn't fast, it's going to be 123. It ain't going to knock your socks off. So fasting, get over it. What about if you fat load somebody? So somebody in years past, this was 1988, decided they'd do like an oral glucose tolerance test, except with fat. So they gave them a gram per kilo of fat orally. So what happens? Well, their numbers will shoot up. The triglycerides in this case starts out normal. Oops, sorry. The speed button. It starts out normal at 100, but it peaks at less than 250. So if you have normal metabolism, you're not going to shoot up to 1,000. And realize that the kind of standard American lunch here is, if you look at the fat content, it's only about 40 grams. So a gram per kilo, if you're 90 kilos, 200 pounds, that's going to be twice what you see here. Again, healthy individuals, the vast majority of them are not going to shoot their triglycerides out the roof. So when you see the kids who have triglycerides, fasting or non-fasting, doesn't matter, 500 and above, they have some underlying abnormality. Could be genetic. Most of the time it's polygenic rather than monogenic, but they have something driving that agenda. These are not healthy individuals who just came in off the street. So what's the ideal age to test cholesterol? Anybody have a guess? Anybody have a favorite age? Well, it turns out that this data is actually known. So if you look here, what we would like to do is say, okay, let's just incorporate that into newborn screening. Good idea. Okay. The problem is, if you look at this top graph, this is total cholesterol. That's about 50-50 using total cholesterol. Now you can do better if you do LDL cholesterol. You can get it up a little bit over 80% in terms of positivity. However, the sweet spot is really between 1 and 9 years of age, where you can get about 88% positive results with a 0.1% false. I mean, that's pretty good odds, right? So if you're going to test kids, they're fair game in my mind between 1 and 9. The reason I bring this up is because we've kind of implemented in our neighborhood clinics. We have 6 or 7 neighborhood clinics. And typically what we do is we incorporate that into the 2-year visit. So Cook was kind enough to buy point of care test equipment. We put it out there. The pediatricians agreed. We just set it up as part of their protocol. So they get height, weight, prick their finger, because they were going to get their finger pricked anyway for EPSDT screening. There's no additional test. They do point of care. They put that slip on the door for the pediatrician. They can talk about it right there at that visit. We also implemented kind of a referral cascade. So we said, if the kid's LDL cholesterol levels less than 130, business as usual. If it's 130 to 160, get a dietitian to see them if you can, give them counseling, retest them in 6 months. If they're 160 and above, they just automatically refer the kids. So we kind of take the burden away from them. They don't have to do any thinking because they got too much to do anyway. So the sweet spot's 1 to 9. So why do we say 10? Well, because we all got in a room and thought we knew better than pediatricians. We didn't have the courtesy actually to invite in these people in the room. And we decided that pre-pubertal at age 10 was a good idea. All right. So Mike asked about lipoprotein A. Anybody ever heard of it? So it's the bad cousin of LDL, if you will. So what I usually tell moms is, if you have a sweet little 6-year-old and he's well behaved and does everything you ask him, and you have another 4 or 5 little boys come over comparable age that are reputedly the same in terms of their behavior, you put all 6 of those little 6-year-old boys in a closet. Because if you turn them loose in the house, that's what a polygenic disorder looks like, right? Chaos. And if it ever gets real quiet in the next room, when you got those 6-year, that's when you got to go, right? I suspect it works the same for girls. Is that correct? All right. So the Europeans just came out with some new guidelines. This is really growing. 20% of the world population actually has an elevated LP little a, 20%. I don't know what the world population is, but it's a lot of folks. By the way, anybody ever had their lipoprotein? Well, I guess you shouldn't raise your hand, but please do. It's again, the same LDL cholesterol molecule with this little Kringle unit. Kringle's just a word for Danish pastries. Somebody thought that's what they look like. But because of that, this actually has homology to plasminogen. So plasminogen, if you remember, dissolves clots. So that's why this molecule is actually a threat for stroke, particularly in young kids, because it ties up the receptor and doesn't allow a clot to dissolve. So if you have any kind of insult, and we all do every day, that forms a clot, it just starts rolling downhill like a snowball because it has no way to resolve itself. Okay. But it's also proatherogenic. So as you get older, this doesn't have any kids, but you can start seeing at some point evidence of atherogenesis. So what these folks were able to show is a couple things. One is that there's not a dichotomous relationship. So if you say, well, what's the normal level? The answer is the lab's going to report in nanomoles per liter, which is the measure of particle number. So if you see the old labs reporting milligram per deciliter, that's mass. That's not very helpful. There are some cutoffs there. They say 30 to 50 milligram per deciliter, and there's no conversion factor. So you're better off if you measured in nanomole per liter because it's particle number again. So you kind of see a theme here, right? ApoB, particle number for Lp(a). It's a continuous variable. So what happens is that, yes, you can actually, this can be an atherogenic factor or a stroke factor, depending on how many other risk factors you have, even at a low level or quote normal level. But as you get to the extreme levels, what they showed was that starting around 40 years of age, the risk of atherosclerosis in an atherosclerotic event like a heart attack or stroke goes way up. And it's dependent upon the concentration. So again, we're back to particle numbers. Just think about a snowstorm, right? Just showering your vasculature. So we have a fair number of kids. And again, to the far right is the nanomole per liter, 230 to 350 is the top number. We have a lot of kids in that range if you start screening them. So their risk of atherosclerosis is extremely elevated. Now, they may or may not have an informative family history because they have young parents and a lot of times single parents that the family history kind of falls apart after the first generation. What they also showed was, okay, so we don't have a drug to lower Lp(a) yet. There are two in development that look very promising. They kind of got put on side because of the COVID thing. The FDA has been fooling around with COVID. But now they're coming back to the forefront. They seem to be quite safe, and that's the first and foremost thing we want to make sure of. Number two, they'll actually reduce Lp(a) about 90%. So if you have those kids in the 400s, they don't need a 50 nanomole per liter reduction. They need a tremendous amount of reduction. So these are very promising drugs, and I think you'll see these on the market pretty soon. But what they showed in the meantime is you can actually calculate. So this is Lp(a). This is the percentile. So the 50th percentile is actually 20 in nanomole per liter. But it shows that there's an increased risk. So the hazard ratios in that fourth column there goes up to 2.5 for the 320 range. But what you can do is they computed, if you start early enough, how much LDL cholesterol reduction can you get with putting them on a statin? So that's our current strategy, is if you have high enough Lp(a), we'll actually give you a statin short term to reduce your risk until a more effective and more targeted drug therapy is available. It also keeps them in the loop. Otherwise, you tell them, yeah, you have a high risk of atherosclerosis, your kid's 8 years old, come back to see me when you're 60, I ain't working, right? Because I ain't gonna be around. So for a lot of reasons, you want to kind of keep these folks informed. It's also important in my mind to tell young ladies, look, since this is a proatherogenic and prothrombotic agent, you probably shouldn't be taking estrogen containing birth control pills, right? Because there's an added risk there. So at the end of the day, to my mind, there's a lot of reasons to know this. But that's a strategy that's used by many people, including ourselves. So what are the tools available to identify kids who are at the highest risk for atherosclerosis? Well, there's several. One is what you all know very well, conventional risk factors, okay? Obesity, insulin resistance, poor diet, sedentary lifestyle, health behaviors, social determinants of health, you know, the whole list. Family history is a bit disappointing because if you take a fairly comprehensive family history, which all of you do, you missed about 30 to 60% of the kids who have significant hyperchloesterolemia for a variety of reasons, okay? It's incomplete, unknown, and often inaccurate. So the way we do it, we have my nurse go in and take a fairly extensive, we have a little chart that they kind of go through. And she kind of does the preliminary work. What that does is she's kind of the warm-up act, because when I go in and try to verify that, they've at least given some thought to the family history now, right? She asked me about my grandmother, but I made a mistake, so I'm not going to correct it. But it's about 3 or 4 visits in that we get a reliable family history. Risk calculators. I don't know if any of you have been to your health maintenance visit recently, but your internist is going to sit down and give you a little calculation. They plug it into a computer. This is based on some algorithms, but it's basically predicting how likely are you to have a heart attack in the next 10 years. That's a great conversation. I will tell you what's really unfair about that is age is a huge weighted factor in that. So as you go up, even though you have a pristine health history, you exercise every day and you eat right, as your age goes up, your risk factors will start jumping up, right? Well, based on that one criteria. But the magic numbers are 7.5 and above. So if your chance of having a heart attack or stroke is 7.5% or higher for the next 10 years, going to have a serious conversation about usually drug therapy. However, people who have familial hypercholesterolemia are already in the highest category. The risk calculators don't help you. And we don't have those kind of tools for kids less than 18 because it's so age sensitive. You plug in any kid at less than 18 and they're going to tell you they're going to live forever. What about genetics? Well, currently the recommendation is that every child that you think has FH, for whatever reason, clinical diagnosis, family history, they should have genetic testing. It helps the child and the parent understand why you're recommending treatment, either lifestyle changes, medications, or both. And it increases our understanding of the genotype, phenotype, which can be quite variable. If you turn up a genetic variant, and there are 4 of them, 90% of them are going to be the LDLR receptor. Then you can actually use that genetic marker to test the rest of the family, and you'll come up with some very interesting findings. Most of the genetics lab, like in Vitae, if you turn up a mutation, they'll actually do the family members free. So it's a nice deal. But we've diagnosed a number of parents who had no clue what their cholesterol was, probably never got tested. They're young parents, but they clearly have FH and they needed to be treated because dad's 28. We've had a couple of parents like that, 28 to 32, who've already had 40–50% occlusion of their artery by the time, we told them the diagnosis, go get seen. We need you around to take care of this kid. What are the LDL cholesterol values in those with and without mutation? So this is sort of interesting because if you look at this data, Joe, which one of these is that the button? Oh yeah, okay, sorry. So if you look, these the light colored blue or gray are the people without the mutations, and you notice that they have a mean of 130 milligram per deciliter, which most people would consider quote normal. That's different than healthy, but normal. But look at the overlap. So some of these people actually have LDLs of 190 to 250 or more. Conversely, this is the interesting part for me. If you look at the dark blue, these are kids or individuals, adults as well, who have an LDL of 190 on average. But some of them actually have LDLs that are quite normal, and some of them have LDLs that are quite low. Realize that 7% of the world, of the US population rather, has LDLs less or greater than 190. So if you look at the math, it's about 24 million people in the US. That's a pretty good sized practice if you were in internal medicine, right? Family medicine. And by the way, that 24 million people usually have on average at least 2 kids. This is not a somewhat dominant condition. It means that one of the kids is likely to have it. Sometimes we go 4 for 4. So what's the role of genetics? Understanding the whole picture. A healthy 14-year-old male whose mother has an LDL cholesterol of 223. Everybody agreed that that's pretty high. So that's an FH diagnosis right there, if there's no secondary causes. But his test results are sort of interesting because his LDL cholesterol was 42. Now, does he have FH? Well, the answer is you don't know. If you look at this pedigree, the maternal side of his family The maternal side of the family actually have the FH gene. So you lost grandma here from, thank you, lost grandma from an infarct, a fatal myocardial infarction. So his mother has the gene. On the dad's side, interesting enough, he has a gene mutation that lowers cholesterol. He has an ApoB mutation, right? So if you have an ApoB mutation, you can have either high cholesterol or low cholesterol, depending upon what the mutation is. So his brother actually turned out, this 18-year-old brother turned out to have the same LDL cholesterol, but he got the hypocholesterol gene. This boy got both, but obviously the hypo gene offset the elevated gene. So he's treating himself. Pretty cool. Not everybody has that opportunity, right? However, when you counsel this 14-year-old at an appropriate age about the next generation, so you say, son, do you ever plan on having a family? It's kind of an oxymoron when you're talking to a 14-year-old, right? But when you counsel this kid or his family about the next generation, what's going to happen in his family? Could he have a child with pure FH, just like his mother? Absolutely, right? So we had a homozygous lady who had one child, a 10-year-old girl. The pediatrician knew to test the kid. The kid's LDL cholesterol was 120. The pediatrician says, good news, your daughter doesn't have FH. Okay, but the mother's homozygous, so she's only going to give up one of the affected genes, right? So how does that work? Well, it could have this, but not likely. So it turns out that she actually had the same gene, one of the genes that the mother does. She's heterozygous. But the importance of that is we didn't necessarily think that she needed to be treated, but her children could. So if we send her out patting her on the back and say, you don't have this gene, it's going to get a little confusing later on. Now, here's the ugly truth. You round up all these folks that have LDL cholesterol 190 and you say, okay, well, how many of them actually have the gene mutation that you can show? It's less than 2%. So that means that if you test enough kids, you're not going to find a mutation. So you have to be very careful about that conversation, because when you tell the parents that their child doesn't have the mutation, but they have an LDL cholesterol of 250, they need to be treated. But you understand the problem here. Parents don't quite get it. Some parents want to do genetic testing so that they can tell you that they don't want the kid treated. So just be careful about that unintended consequence. The truth is, whether you have FH that's confirmed by a mutation or not, these are compared to people who have an LDL cholesterol less than 130. If you have an LDL cholesterol 190 and above, your risk of having a heart attack, stroke by age 50 or 60 is about 22 times higher than the general population. If you don't have a mutation, but you still have high cholesterol, it's about 6 times. Anybody like those odds? No. Anybody understand genomic risk scores or genetic risk scores? And neither, well, this is really a hard one to convince the general public or general pediatricians, but the concept is if you have a single mutation, autosomal dominant, it's pretty straightforward Mendelian, right? So you have this mutation, you can demonstrate that, you can demonstrate it in the relatives. They have high cholesterol, need to be treated. If you have a gene variant that has a small effect, so it does affect the cholesterol pathway, but not significantly, so it never raises the cholesterol. Okay, so we all have those. However, if you have all those little 6-year-old boys in the same room, now you got a problem, because these folks act just like these folks, except you can't show this mutation in that group. So these are the ones that are going to come back negative. They have a polygenic disorder. But you can get at that actually by this genomic risk score. So what they do is they take all these variants, put them in a little chip, and then you can test it and give a probability score. And you can occasionally have somebody who's hit the trifecta here, where they have, family history, they have the single gene mutation and a polygenic disorder, and they're probably going to have an MI in their 20s. So if you look at the UK Bio Data Bank, they collected over 500,000 people. And what they showed was, if you look at conventional risk factors, which we all know, this genetic risk score actually outperforms all of them. Also interesting if you look at conventional risk factors, if you add them all up, that actually performs better than this one. However, they're additive. So if you add those two together, you get even more predictability. This is a germline polygenic risk score. So it means that we could actually use this in newborn screening, right? Because we know it right off the bat what your polygenic risk score was going forward. So it's a valuable tool. It's obviously going to be hampered by cost. But keep that in mind, because I think this is something that we'll kind of have more conversations about in terms of newborn screening. So the answer to my question is you want to use all these tools. So do the best you can on family history. Try to identify and modify things that you can. It's a moving target. And then give some considerable thought to the at least monogenic testing, but make sure that you prepare the family for the answers. You're either going to have a positive variant that needs to be treated. You may have a variant of unknown significance that probably needs to be treated. And then you got the negative one you're going to have to explain, but they probably need to be treated as well. Now, what do we have to treat these kids with? Well, an increasing number of drugs that are FDA approved for children. However, they're only approved for kids with FH, however you define it. So make sure you have something in your chart if you want to use a statin under the FDA guidelines that meet some of these guidelines. But there's an increasing number of drugs that we have available for these kids. You're welcome to use any of these drugs like you would any other drugs off-label. Be sure that you have a conversation with the family and make sure that you document that conversation. But what we're lacking really are these drugs for triglyceride problems, which is what you see a lot in your clinic and frustrated by because they have triglycerides that are persistently 250, 300, HDLs that are 20, and you can't get that fixed. If that triglyceride is less than 500, the recommendation is actually to use a statin, not gemfibrocil or fenofibrate or omega-3 fatty acids. By the way, omega-3 fatty acids may actually increase the triglyceride because they're fatty acids. But when people come in and say, yes, my kid's taking omega-3 fatty acids, so what are they taking? Gummies. Well, that's okay because they're homeopathic. I mean, they're like, there's nothing in it. I said, well, what do you take? I take the same thing. I just take a couple more than she does. Okay, good. Keep it up. The over-the-counter omega-3 fatty acids are not a good idea because they come from cold water fish and they're unregulated. So you don't know what you're getting. But if you're giving that pill to a kid for the next 50 years and they have a small amount of mercury, there is some risk that that kid may actually wind up with toxicity. So if you're going to use it, use a prescription strength. But the pharmaceuticals, all pretty much what I've shown you, are pretty safe. At least our experience has been safe, even statins. But don't be in a rush to put a kid on a statin at 6 years old. I'm not hesitant to treat a 6-year-old. In Europe, they usually start at 5. We typically start at 8 to 10 because that's where the FDA approved those drugs. But the reason I say don't be in a rush is because this needs to be a lifelong therapy. And if you scare the folks off, you scare the kid off, you've done them a disservice. So we have 2 criteria. One is we want to do the best thing to keep your child healthy their entire life or as long as we can. And we want to make sure that the mom sleeps at night. So you tell me when you're ready, we'll do it. But it usually takes a couple of visits. At the end, Dr. Dixon knows this trick very well, but a lot of you younger folks are probably anxious when people say, well, what would you do with your child, doctor? Is that true? I mean, they ask you that all the time, right? So now I actually start with that. I can't tell you what to do with your child. I know that your precious little baby is the best, the most important thing in your whole life. Here's what I think I would do with mine. You just lead with that question, and then they seem to be very comforted by that. Or they say, hey, you're too old to have kids. Okay, well, let's change the paradigm. How about grandkids? They're even more important, right? Goals of treatment, we want to try to get the LDL down to less than 100 if we can, or the best you can. But typically, with no questions asked, 190 and above, those kids need to be treated. It's just a matter of when you want to do that. And then 160 and above with additional risk factors. Again, the genetics is important, but it's not the criteria by which we decided to treat. 20-year follow-up, we can show that the kids in the red line here, so these kids were started on statins in their teenage years. You compare them to their parents already started having events at age 25. Some of them were dead by the age of 30. These kids have actually done very well. No side effects. These are again a list of drugs. I'm not going to go into these except to say bempedoic acid is currently undergoing trials in children. Bempedoic acid is a nice alternative because sometimes the parents have had myalgias or myopathies with the statins. This drug it's an inactivated product until it gets into the hepatocyte. Then the hepatocyte activates it. It's actually higher in the chain than the statin drugs, but it doesn't get activated in the muscle cells. So once you tell parents that, they say, oh, this is great, let's do it. That and the gummies. So early identification of these children are extremely important if we're going to prevent cardiovascular disease. Fasting is not necessary. Please help me carry that word to the general pediatricians. And then pharmacotherapy is necessary and life-saving, but it takes a little bit of finesse. The science is pretty straightforward. The delivery needs to be finessed a bit. And with that, I hope you'll go out there and start testing everybody, including your kids, grandkids, neighbors, kids that show up randomly at the door wanting, donations for their sports club, whatever it is. Thank you. Yeah. A cholesterol test also is a very nice birthday gift or Hanukkah, Christmas.
Don, thank you. Thank you for the talk.
You're welcome.
It's great. Can you all hear me all right? Okay. So I just wanted to thank you for talking about this area of medicine, which is so important. And as far as preventing in future generations, I think especially we find it fascinating about lipoprotein A. And I was really happy to hear that there's some studies going on and some treatment for this, because I think we feel at a loss when we measure these levels and they're through the roof. And what can we do about it? Start statins, like you said. But then also, I think lately we've been talking about sending those kids to hematology, maybe cardiology to talk about, other risk factors for cardiovascular disease. But and I know maybe it's another talk in itself regarding those medications, but what else can you tell us about those treatments that are hopefully going to be coming out sometime soon?
Well, they will be available because this, again, affects 20% of the world population. If you have a known mutation like FH, it's about 30%. So the worst of kids who have the inoculated variant, an LDL cholesterol greater than 190, and have no those, I shouldn't say worst because then you have even seen homozygous disease, so they have two variants. That's the worst. Those kids have horrible outcomes. That's the first child I saw in Tulsa when I was here in the 80s. A little 3-year-old came in from short stature, so be alert. And I said to this sweet little grandmother, why did you come? She said, because he's got these warts all over his knees and we can't get rid of it. So he had xanthomas. But that child, so in those days, called the NIH, they said, well, our protocol started 10 policy was still alive. But what I did was actually I trained down in Houston. We were doing some plasmapheresis on kids with rheumatologic conditions like systemic lupus. I just took them over to St. Francis, started dialyzing the kid. I'm really excited the numbers came out well. I was sucking off the kid, but that seemed to work for a while, and it was very difficult to maintain. So that child died of heart attack at 14. So the shot knowing very well.
Do you want to, we'll see if there's any questions in the chat here. Not seeing any. Okay, for the audience, back here, Mike. Do you want to double check?
Hey, Don. So I thought like in adults, cutoff for treatment with LDL was like if they're above 160 or above 130 with risk factors, diabetes and whatnot, and you were using 160, 190. So I'm wondering, one, is that still true? And if it was, would we get like teenagers, especially our diabetics, and they're 15, 16, they're getting ready to transition, would you lower those LDL?
No, so remember that in the adult world, they actually have a couple of other tools. We talked about the risk calculators. So what the adult doctors do is they measure risk factors, including cholesterol, blood pressure, blood sugar, A1C. And then they plug in some numbers to the risk calculator. So they look at the risk calculation, the family history, and then the numbers. So they may, in their own mind, kind of adjust that number depending upon all those variables on an individual basis. Great question, though. So we've kind of arbitrarily decided those, Mike. If you have a known family history, so you have a parent who has a variant, the cutoff for FH is 130. So if you have a kid with 130 and above, you assume that they have FH if the parent has an informative variant. So it's a moving target. The other thing I can tell you is that, let's say you have lower, so if you have high numbers like 190 and you've excluded any secondary causes, so make sure they don't have hypothyroidism or liver disease or medication effects or whatever. But what I told some of the families who are sort of hesitant is that, look, why don't we treat your child until they get to be 21, 22? Now they go to the adult world. We can use other tools to see if they need it going forward. But now we've kept your child's blood vessels healthy until that point. What's interesting is that when you start a statin in a 10-year-old with an LDL is, let's say, 250, not only does that level come down, but if you look at CIMT measurements where you have buildup of cholesterol in the vessel, you'll see it sucked out. If you ever seen these homozygous with xanthomas, like that kid I decided, you'll suck those flat when you give them like apheresis or whatever. So you can suck cholesterol out. So I tell the parents, look, your blood vessels at your arteries should be elastic, right? But if you hold that big old rubber band out there long enough, what happens? You don't get the recoil. So there's an age by which you can't reverse the damage to the blood vessels. So you can stabilize adults, but you can't reverse it. You can reverse it in kids. So again, one of my aims is get the kids to a young adult age and let them have an adult conversation with folks who can use other things. You can also use calcium scoring. We don't do it in kids because you got to do a CT of the chest, but you can look for a calcium score. So a lot of other things you can do in the adult world, but I wouldn't be hesitant to take a 24-year-old off a statin and reevaluate. I'd be a little bit leery of doing that in a 48 to 50-year-old, particularly if they've had any symptoms or they had a stent. They say, well, okay, at 48, what happens if I stop my statin for a while? Well, you may die. I don't want to roll the dice. Yes, ma'am.
So along with that testing, when you think about the kids with FH, because basically treating them the best you could, whether it's apheresis and all those other things, like the idea of calcium coronary scoring or even some of the carotid modalities, IMT, really doesn't make a lot of sense. It's not going to give you more information, but I'm thinking more in those polygenic individuals. It does seem like there would be role, and I don't know if there's any literature to support it, as they transition to see how much burden do they have.
Right.
Because as better drugs come out, the other next question is going to be, how aggressive should we be for cost and side effect profile? So some of those modalities that we know we don't want to do in pediatrics, and even the carotid IMT would actually be very good in pediatrics.
Yep.
If they're, and I know there's some early studies with it, but do you know of any further development in those areas? Because those are the questions we're going to need as these new drugs come out. And as the kids transition, is how aggressive to be with them.
Well, I mean, who in this room would give growth hormone and not look at the growth chart response, right? I think it's what we're trying to do. So you're exactly right. I mean, I think as those technology become more precise and we can kind of count on them, the idea would be that you can use that as a tool to make a decision about whether you should start treatment now or later. You can also see if there's regression in terms of both compliance and effect.
The biggest
Right.
group of kids that really don't want to do are type 1s.
Mhm.
So the type 2s, they have more of a family history. You can sort of paint a different picture. The type 1s, if you identify hyperlipidemia, they're 160, but there's not a strong family history. Oh, you're going to work on their diabetes. But really the question is, well, how aggressive do you need to be with them,
Right.
especially it's a female reproductive age. So at what point, and I haven't done this consistently, but it does make me wonder if I shouldn't, because if you're 40, you're going to get a calcium coronary score. But if you're 20, 25, and you've had type 1 diabetes since you were 5, and they're just looking at this cholesterol as they transition over, there's probably a role for some kind of imaging to
Yeah,
guide how
absolutely.
aggressive should
Yeah.
be in their
The,
20s.
the problem with the imaging is that because we're talking about a growing and developing child, it's a moving target. So people have been a little leery about the numbers. It's a very technique dependent, interpreter intended. So it's not kind of a simple test. As it becomes valid, you're exactly right. And you also brought up another important point. These guys are very good about testing the rest of the endocrine patients that we see. We have probably a half a dozen kids that have type 1 diabetes and FH. You know, they're very thin, their diabetes is well controlled, but they have FH, right? So they got a double whammy. Same thing for CAH or anything. It's 1 in 200 kids. So if you think about 1 in 500 for type 1 diabetes, all of you see FH every day in your practice, just numerically. If you go to any school system, it's got 1,000 kids, you got 4 kids in there that already, 4 or 5 kids that have the disease. Well, I shouldn't say disease at that point because your point's well taken in terms of collection, but I don't know if any of you have been to an internist or your relative have, and they said, yeah, they did this like maybe a coronary artery CT or something, and the doctor comes in and says, oh, you only have 50% occlusion of your coronaries, so we're not going to do anything. You think, whoa. 50%. Yeah, so they don't really kind of get excited until they're over 50%. But Sam Giddings actually published a paper, it was sort of provocative, and he said, well, why don't we do this? Why don't we do the imaging thing and get it perfected and then treat the kids, regress it, stop their therapy, and then keep imaging them. When it builds up again, we'll kind of, clean the shed a little bit. He was being a little bit tongue in cheek, but yeah, it's not a bad idea at all. And it would sort of convince people, and I think some of our colleagues, that we're not just treating numbers. There is a disease process. So just high cholesterol numbers is not a disease, but it can lead to one for sure. Great conversation.